Talk about vaccines and vaccination is everywhere. Almost as prominent are discussions about equity in the vaccination rollout. Are the individuals who need vaccines the ones being most prioritized? The elderly, the immunocompromised, those with comorbidities like obesity and diabetes, and frontline workers in healthcare, education, and service provision. A second discussion regards who is comfortable with receiving a vaccine and who is hesitant. A major concern that has emerged is that those communities that have been hit hardest by the pandemic, Black and Latinx Americans, many of whom bear the scars of racially driven medical neglect and experimentation, are least excited to get it. Hi, I'm Dan O'Brien, Director of the Boston Area Research Initiative at Northeastern University. In collaboration with our colleagues at UMass Boston's Center for Survey Research and the Boston Public Health Commission, we conducted a unique survey of Bostonians that allows us to compare experiences, attitudes, and behaviors during the COVID-19 pandemic across communities, by neighborhood, by race, and by income. A follow-up survey asked about vaccination intentions, which is something others have asked about as well, including our friends at the Museum of Science and the Boston Globe. We wanted to go a step further, though, and take all of these survey results, put them in the context of known patterns of infection and transmission, and find out what the implications would be. How would a vaccination rollout proceed with differing levels of vaccination adoption across communities? What would be the resultant disparities in vaccination, infection rates, and the holy grail of herd immunity? We ran a simulation model similar to those that many of our colleagues in public health and network science have been doing, estimating transmission rates by infected individuals, taking into account movement patterns between communities, and then introducing a vaccination rollout, including the assumption that some of those who are currently uncertain about receiving a vaccine might be persuaded, as they saw more and more of their neighbors receive it with few to no adverse side effects. I'm going to walk through the main results here, though I will note that there is a lot of math and a lot of assumptions to our simulation. If you are interested in those details, I encourage you to read the full report we released today, Thursday, February 4th, 2021, the seventh in a series of results from the survey. Without further ado, let's take a look at a few images that tell the story of what we found. Let's start here with the survey results. By now, this graph, or something like it, may be familiar to many of you, where we see that in the general population, about 50% of people definitely want to get the vaccine, and about 10% of people say they definitely will not. But this is not evenly distributed across ethnic groups. As you can see here, Black and Latinx respondents to surveys, 1 in 5, so twice as many as the general population, and therefore quite a bit more than white and Asian respondents say they will not get the vaccine. Now, what we did is we took these breakdowns across ethnicity and we combined them with actual ethnic composition. So here's a map of the communities that we analyzed in this study, meaning the municipalities throughout the metropolitan region, and we broke Boston down by its zip codes. And here we've classified them for simplicity as being predominantly white, meaning more than 80% white. Those are the purple communities. The green communities are those that have more than 20% Black and Latinx population. And the orange communities are somewhere in between with a certain amount of diversity, but notably not an especially large amount of diversity. Now, we combined this information on racial composition in neighborhoods with the intentions regarding the vaccination across race to estimate how much each community was likely to adopt the vaccine. And as you can see in these maps here, we see the proportion will vaccinate is highest in the outlying predominantly white suburbs and lowest in the Boston zip codes, especially those in the southern part of Boston, where there are majority minority populations. The maybe will vaccinate proportion is the highest in those majority minority zip codes. And the proportion will not vaccinate, again, highest in those majority minority zip codes, as well as some of the majority minority municipalities just to the north of the city on the South Shore, like Revere, Winthrop, and Lynn. Now, when we took this and we put it in the simulation, we essentially ran a 3-month rollout of vaccination based on who we thought was going to be willing to get vaccinated first, who could be persuaded, and who absolutely did not want to get vaccinated. Now, if we look at this graph, there's a lot going on here, but your key lines here are your green line and your red line. The green line is telling us between October and the beginning of January in our 3-month simulation, what proportion of people in a community got vaccinated. And it goes up steadily over time. It's reaching capacity. And then there's a point where there's a kink in the line where we reach a bottleneck, where if you notice at the same point, the red line goes flat to 0. Now, the red line is the proportion of people at that moment who are willing to get vaccinated. So when we hit that kink in the line, we have run out of people who want to get vaccinated. And all we're getting the following week are people who were persuaded from the previous week. So that persuasion is not as fast as our capacity, and we are literally hitting a surplus. We have more capacity than we have people who want to get vaccinated. And it takes about 6 weeks to get to that point in the general population and in predominantly white communities. But if you look, there's a dotted line here. Now, those are communities with more than 20% Black and Latinx population. They begin to hit that spot weeks earlier, right? Somewhere around the beginning of November, whereas it really doesn't hit until almost the end of November for those other communities. And so as a result, the overall level of vaccination in those communities ends up being quite a bit lower by the end of the simulation. And to see that on a map here, right, we have the areas in the far-reaching suburbs quite dark on this map, which means that they got vaccinated up to 80 to 85% in the 3-month simulation, whereas the zip codes inside of Boston, if we zoom in, have some of the lowest vaccination rates, as low as 55% at the end of the 3-month simulation. And the disparities here are just so stark. When you look at areas in downtown Boston, near Chinatown, South Boston, so on and so forth, which are being vaccinated nearly to the level that some of these outlying suburbs are being vaccinated by the end of the 3-month simulation. Now, the question is, what does this mean in terms of infections? So here we've modeled out what infections look like without vaccination over the same time period and with vaccination. Now, those gold curves, the ones that look like exponential graphs, they look that way because they are infection curves without vaccination. Your standard transmission model. And again, the dotted line is high minority communities, and note that that line starts higher and it ends up even higher or even further away from the line for predominantly white communities. Now, when we compare that to the blue line is with vaccination. You see that the blue line takes on a very different shape. After just a week or two, it starts to pull away from the gold line and even starts to go down. That means that infections are actually decreasing. Vaccination is having an impact. And as you notice, it's having that same characteristic impact across communities, no matter what their racial composition. So vaccination is having an effect. It is helping everyone. But if you look out towards the end of December and beginning of January, the dotted line for high Black and Latinx communities is still visibly above the one for predominantly white communities, and it's been above for the entire time. So there's consistently more infections and therefore more cumulative infections in these communities throughout the 3-month period. Now, the last question is herd immunity, right? When do we get to herd immunity? This thing that we're all reaching for in order to get out of our homes and live a new normal again. And so we modeled this as the moment at which a community has 0 remaining infections. And as you can see here, a bunch of communities in the outer lying suburbs reach it in November to December, which is the yellow communities. And then there's a lot more, and almost all of the rest of those communities out there to the outside of the region who reach it in January. But then the purple communities, which are generally communities that are more diverse, don't reach herd immunity until February. And if we zoom in on Boston, again, the disparities are stark. In the highly white areas of the Seaport District, right, the North End, the downtown, you reach herd immunity November, December. The neighborhoods around those, you reach it in January. But then in the communities that are more diverse or majority minority, you don't reach it until February, or in central Roxbury, even in March. And just to put a number on this, if we compare the average community with more than 80% white population to the average community with more than 20% Black and Latinx, there's a 45-day difference in attaining herd immunity. So a month and a half between them, which is rather striking. So, those are our findings. Simply put, if you take into account current racial differences in adoption of the vaccine or intention to adopt the vaccine, we see pretty dramatic differences in terms of infections over the course of the rollout and the effectiveness of the rollout in terms of reaching herd immunity. As we look for takeaways from this, we have three main lessons, I think, that really behoove us to pay attention to, especially policymakers and practitioners. Number one, from where we currently stand, the vaccination will eventually lead to the elimination of infections in all communities. That's a good thing. But there will be inequities along the way, and some communities of color may end up with gaps in herd immunity at the point when we think we're quote-unquote done. This is not a doomsday scenario, but neither is it what any mayor or governor wants for their city or the region. Number two, vaccination in all communities appears to hit a crucial bottleneck, at which point the rollout is going to become dependent entirely on persuasion, and it's going to fall behind the intended pace. We have already seen instances of this during the phase 1 rollout, where certain institutions have run out of people to vaccinate, and policymakers and practitioners should be ready to react nimbly to avoid the misdistribution or even ruining of supplies of vaccine and to get things moving along. Otherwise, we're going to stall. Third and final, the disparities between predominantly white communities and high Black Latinx communities are best addressed through amplified messaging, outreach, and other effective mechanisms of persuasion. We ran another version of the model with no persuasion of people who are uncertain about getting the vaccine, and we did get a doomsday scenario. In that scenario, over 95% of predominantly white communities reached herd immunity, and 0% of communities with more than 20% Black and Latinx population reached herd immunity. So persuasion is critical, but we also have to keep in mind that persuasion, as modeled here, is not going to fully save the day on its own. We only allowed people who were uncertain about getting vaccinated to be persuaded. When we amplified the level of persuasion, it actually only narrowed the gap by about 10 to 15% in terms of the timeline to herd immunity. What this says is that current persuasion and messaging efforts cannot rely on just those who are uncertain whether they will get vaccinated. We are going to need to convince some of those who are saying no that they will get the vaccine, and that this is something important and valuable for them to do for them and their communities. Otherwise, we will end up leaving communities of color with a continued vulnerability to the virus. Thank you for listening. Please stay tuned, as we will certainly have more insights from the survey to come.